lecture in our 2021 spring lecture series for the Center for Values in Medicine, Science, and Technology. I'm Matt Brown, and I'm going to introduce our speaker today. With us today is Keisha Ray, who's an assistant professor with the McGovern Center for Humanities and Ethics at UT Health Science Center at Houston. She earned her PhD in philosophy from the University of Utah, and Dr. Ray's research focuses on the social determinants of racial disparities in health and healthcare, and on incorporating race education into medical school curricula. She's published work in the American Journal of Bioethics and the Journal of Medical Humanities. And it's my great pleasure to hand the presenter's ball over to her and welcome her to speak.
Thank you. Hello, everyone. I appreciate you all inviting me here. So I'm going to go ahead and share my screen so that way I can bring up my PowerPoint. Just give me a second or two. Okay. Okay, so you all should be sharing my screen. So I've sort of timed this talk to be maybe about 35, 40 minutes because maybe about 40 minutes because I think that there's a lot of value in asking questions and having discussion. And I know sometimes these topics can be foreign to some people. Some people are aware of the basics. Other people just want to have a conversation with a group. And so I always try to have a disclaimer with this kinds of conversation is that this should be a space where we can be open, where we can discuss these kinds of things, and where we should feel free to be inquisitive and to just to be open and to be respectful. For me, I've heard all the questions, so no question should be off limits. The only questions for me that would be off limits are those that question the humanity of Black people. Other than that, we can get into deep discussion because this should be a safe place. So what I want to talk to you about is this idea of being Black as being bad for your health, and really just the determinants of what creates health for Black people. So my plan is to talk about Black bioethics. It is my approach to Black health. It's my approach to bioethics. To talk about race and racism as a social determinant of health. I'll briefly talk about that. I know many of you are very familiar with social determinants of health, so I will briefly discuss it. Also, we will talk about two examples, environmental injustice and Black maternal mortality, to sort of frame Black bioethics and racism as a social determinant of health. We'll talk about structural racism in healthcare. And then I think it's really important for these kinds of talks to think about solutions, to think about what can be done at the institutional level, but also what individuals working in healthcare and researchers and scientists can do to talk about race and to sort of contribute to a solution of racism in research and in healthcare. So first, just want to talk about briefly just what it means to talk about racial disparities in health. So racial disparities in health look at the effects of race on people's health, right? So in America and in other places as well, particularly places like the UK, race presents differences in life's opportunities, exposures, and stressors, right? But there's a direct correlation between the differences in life opportunities, exposures, and stressors that are related to race to prevalence of disease. So there's a direct link between what race you are and your prevalence of disease, your experience of illness, negative side effects of therapies. All of these things tend to fall on racial lines. And what we are finding, particularly in America, is that if you're white, we are finding that you're having better health outcomes. If you experience disease, your outcomes will be better. You're also having better outcomes with healthcare, in particular, interactions with physicians, interactions with nurses, even interactions with staff, like for administration, like for billing purposes and things. And so there's differences in access to healthcare, and there's differences in how you experience healthcare. And some of here I just listed some well-known racial disparities in health, like there's a well-known racial disparity in cardiovascular disease diagnosis and therapies. If you are a Black person, particularly a Black man, you are less likely to survive a heart attack than you are if you are a white man. You are also, if you're a Black man, more likely to survive a heart attack if your doctor is Black than if your doctor is white. Black people are less likely to be recommended for more interventions if they come into the ED with chest pains. Black people are more likely to have leg amputations from their diabetes complications. Black women, even though they make up a small percentage of breast cancer rates, they make up the most breast cancer deaths. Pain management is another well-known racial disparity in health. In pain management, Black people have their pain mismanaged more. Even when they are prescribed pain management like opioids, they are scrutinized more. They're giving more urine tests than white people. This even extends to children. There's research that shows that the Black child and the white child both come to the ED with the same problem, to say like a broken leg, that the Black child will be less likely to receive strong pain medications than the white child. Maternal mortality, which I won't go into, we'll talk about today. Infant mortality, Black people have a higher rates of infant mortality, particularly if the infant who is sick has a doctor who is white. Black infants that have complications are more likely to survive if they have a Black physician. And overall mortality, especially now with COVID, Black people have lost 3 years in 2020 off of their overall lifespan compared to white people's seventh of a 10th year. And this again is already was already a problem, especially for Black men who have the lowest rates of lifespan. So this is just to give you an example of some of the things that I've written on Black bioethics. There's also another piece in the American Journal of Bioethics special issue on race that came out a couple of months ago. But Black bioethics to me is how I do my research. I essentially ask the idea, what does racial justice in healthcare? What does racial justice in public health? What does racial justice in health and biomedical research look like for Black people? So what would these areas look like if they were participating in anti-racism behaviors and attitudes and activities, right? So Black bioethics to me asks the question, how do social events, how does technology, how do practices that we incorporate into our healthcare, into our public health systems, how do they then affect Black people given the poor relationship between Black people and public health, medicine, healthcare, etc. So here you can see some of the questions that I might ask. So if I use the lens of racial justice for Black people, again, it's what does it mean to consider race, racism, anti-racism, and racial justice in bioethics? And what does racial justice mean for Black people? What does it require of our systems? And then also, how do we learn from medicine's mistakes of Black people? And for one instance, we can talk about this in the Q&A. So one thing that I think about is reparations and COVID-19 vaccinations. So many times when people think of reparations, they think of monetary reparations. But for here, there's a lots of ways to sort of repair the relationship between Black people and medicine. And one way is to kind of rethink how we distribute COVID-19 vaccinations. So early on, we were distributing vaccinations. The first tier to qualify for a vaccination were people 85 and up. But if you think about the typical lifespan for Black women and Black men are around mid 70s, like 75 to 77. So if you start off saying 85 and up, you're already cutting out a large portion of elderly Black people because Black people just don't typically live as long as white people. They don't typically live to 85 years old. So if we're going to talk about how do we have reparations, how do we make public health anti-racist, we have to rethink these sort of structures that are in place, like COVID-19 vaccinations. And even thinking of, Black people, Latinx people, and Indigenous people are the people who were mostly affected by the pandemic, yet they are the least vaccinated people. So having these different systems where we make sure that the people who are the most affected by COVID-19 are the first in line to get the COVID vaccinations. This is how I think about Black bioethics when I'm looking at healthcare issues, public health issues. So this is just an example into my mindset. So when I think about Black health, I think about identities, right? Black people have social, cultural, and political identities for better or for worse, right? And I think about how those identities then interact and intersect with each other to create poor health and poor experiences with healthcare. I try to come at it with a interdisciplinary framework because looking at it just from a legal perspective or just from an economic perspective, even just from a health perspective, doesn't quite get the problem right of what is plaguing Black health because of the intersection of our identities. So I try to situate Black people's identities within the institutions that shape their health. So within institutions like housing, I think about the effects of legal and illegal segregation. Healthcare, I think about provider bias and how that hinders Black people's health. Think about in terms of economic and thinking about different pay scales for Black people versus white people. And then, of course, legal, things like healthcare laws, things about healthcare protections and environmental protections that allow private businesses to pollute the air and water of people who live in predominantly Black and brown neighborhoods, which we will talk about. So here's just a list of social determinants of health. I'm not going to go over too much because I know many of you are familiar with it. But for those of you who aren't, I just look at social determinants of health and how we look at it in bioethics is just these social factors that influence our health. And it's sort of thought that the more access you have to the things on this list, the better off that your health can be, right? And if you don't have access to them, then it can affect your health. Things like housing. Housing for me is always the number one social determinant of health because where you live tells us so much about you, right? We can know your income, we can know your zip code. And from your zip code, we can tell if you have access to clean air, clean water. We can tell if you have access to recreation, to parks, safe sidewalks. Is there grocery stores in your neighborhood that have healthy food? What kind of schools are located in your neighborhood? And if you see all those things that I listed are all part of social determinants of health, right? So for me, housing is very important, but there are other things, transportation, any adverse childhood experiences. These are all social determinants of health. And the one that we're going to mostly focus on today is housing as well as access to clean air and clean water. And then, of course, racism. And racism is an interesting one because racism and our experiences of discrimination can affect our health, but also racism is a part of all the other social determinants of health. Racism is a part of access to medical care, social order, transportation, access to recreation, all these other parts, and we'll continue to talk about how they sort of intersect. Sorry, next slide is not going. There we go. So racism as a social determinant of health. So racism, just so we all have this idea, this definition, philosophers love their definitions, right? What we're talking about here when I say racism. So racism, we think about the system of structuring opportunities so that some people have advantages and some people have disadvantages that are attached to their value of the skin, how society values their skin color. And we think about it in two veins, right? There's a structural and institutional racism, and that is when you have systems in place that have racism within them, like healthcare, education, transportation. And then there's the everyday personal racism, where it's people interacting and someone may say a racial slur or make a racist statement, right? So there's two different kinds of racism. Both are important, but here we're focusing on the structural and institutional and how there are disadvantages for some people and advantages for other people. So if we're talking about racial disparities in health, we have to look at the wide-ranging causes of racism and how racism has these far-reaching effects on people. And so what I want to make it clear throughout this presentation, and I hope that you will see that, is that it's not race that's the problem. It's not that Black people are inherently inferior, inherently unhealthy, and inherently have biology that makes them prone to poor health outcomes. It's that racism is the problem, right? Racism in institutions, racism in social determinants of health make it so that being Black becomes bad for your health, right? So it's not that being Black is bad for your health, it's that racism is bad for your health. So here looking just very briefly at racism and its effects, right? Racism has wide-reaching effects on social, economic, psychological, and biological well-being. Even the threat of racism or the preparation for racism, like if you are a person of color and you walk into an expensive store and you believe that the staff is going to follow you or believe that you don't belong there, right? The preparation can have effects on our well-being. Um, and if you look at, racism is an inherent part of being a person of color. And this is why it's hard to separate race from racism because of our society and the ways that we attach advantage and value to skin color. They're sort of intertwined, and we can talk about that in the Q&A. Actually, I'm gonna skip that one. So if you are a healthcare provider in here, what I really want you to think about as we're going through these examples is what do your Black patients go through before they have to see you, right? Think about transportation, thinking about childcare, taking off of work, paid time off, paying the park to come and see you, insurances, co-pays, less access to social terms of health, the structural and the personal racism that they experience. And why this is important is if you're a healthcare provider, many times we see patients and we're seeing them at their worst. We're seeing them when they're ill. We're seeing them when they are worried, when they are stressed out. And on top of that, there's all these other structural barriers that are unique to people of color, right? For transportation, some public transportation doesn't go into Black and brown neighborhoods past a certain time. There's studies that show ride shares like Lyft and Uber charge higher rates in Black and brown neighborhoods. Many people of color work jobs where they don't have paid time off. And so to take time off of work to go see a doctor means that they are losing wages. They have to find childcare, which means they have to pay for it. And then they have already limited income because Black people and brown people tend to get paid less, but now they're having to pay co-pays, they're having to pay the part. And this is on top of all of the other daily stressors. So just something to think about. So let's get into the first example. So the first example I want to talk about is environmental injustice. Sometimes you'll hear people call it environmental racism. I myself sort of interchange between those terms, so you might hear me say environmental racism. Oh, there we go. So the first thing that I want to talk to you about is Cancer Alley. Some of you may be familiar with it, especially if you are from the South like I am. You may have heard this term Cancer Alley. So along the Mississippi River, particularly in Louisiana and Mississippi, there is an inordinate amount of facilities that emit toxins, like refineries, toxic landfills, oil facilities, but also in this area are predominantly Black neighborhoods and predominantly brown neighborhoods as well. And what we have found is in these neighborhoods, there is an extraordinary amount of cancer, people who are being diagnosed with cancer. In some cities in this cancer alley, they are 10 to 15 times the national rate of cancer. You have entire families that are being diagnosed with cancer. This was brought to the attention of the EPA. The EPA went into these neighborhoods and started testing out the soil and found just large amounts of toxins and carcinogens in the soil and in the water. And so what they did was to sort of pacify the people who were angry about this. They went in and only on the areas of the earth that were exposed, like yards and that kind of thing, they went in and put a net in between the toxic soil and the topsoil to sort of prevent it. But it doesn't really do much, right? It's a net, right? It's not gonna make carcinogens, excuse me, stop from getting in the soil and the water. The people who live in these neighborhoods really are sort of stuck. Government has really said you're on your own. This has been a decades long protest, a decades long process for them. They can't sell their homes because no one wants to buy homes knowing that they are having these issues with cancer. And meanwhile, you have people, especially children, getting sick from the vegetables and fruit that are being grown in the backyards. You have schools, you have senior citizen communities. All these kinds of communities are built on top of toxic land, and they're breathing in air with carcinogens. And again, these neighborhoods are 98% Black, and some neighborhoods are a few more brown people, but predominantly Black. And these kinds of facilities are not built near white neighborhoods. And so the people who live in these neighborhoods have to sort of live with that, right? They know that the reason why these facilities are being built there is because no one is really caring about them, right? And many places like Exxon, BPA have plans right now to build even more facilities there that will emit more toxins. And the people's protests and words are just sort of being lost, right? They're just sort of dying off. And their homes are literally unsafe. And right now, with the pandemic, I think we're really seeing the importance of home when many of us, for a very long time, were tied to our homes, right? We had to be at home because it was unsafe to be out in public. And think about if you were forced to be in your home, knowing that your home is literally killing you and your family, and there's not much to be done about it. In my city where I live in Houston, Texas, there are people here in the predominantly poor and Black neighborhood of the Fifth Ward is also having an environmental racism issue with Pacific Union, the railroads, where their materials are emitting toxins in the air and in the soil. And people here have higher rates of cancer just in this predominantly Black neighborhood. So environmental racism is an issue for poor people, and it's an issue for people of color, as you've also probably seen in the Flint, Michigan water crisis, right? If you look at the population makeup of the city, most of the residents are Black, most of the residents are poor. Not only did they deal with the contaminated water, then afterwards, they dealt with Legionnaire's disease, right? The severe form of the flu that was hitting these Black residents, particularly in children. And again, the administration is just now having some legal consequences for knowing about what this water was doing to the community and Legionnaire's disease, and then doing nothing about it. But there are many residents to this day, right now in Flint, Michigan, who still don't have clean, accessible water. Now, think about what this means for overall health if you don't have access to clean air and clean water. If clean air and clean water are a social determinant of health, think about what this means for Black and brown people's health in this area. It means that they don't have proper housing, they don't have access to clean air and clean water, they don't have access to safe recreation because it's not safe to be outside. Think about childhood experiences. Cancer is clearing out entire families. You have children who are watching their family members die. They have children who are watching the trauma of environmental injustice. And then hopefully those children grow up to be adults, but now they're adults with childhood traumas, and that affects health. And then also, these people are living with the idea that this is happening to them and no one is caring because of their skin color. No one is caring or doing anything about it, like they would if this were happening in a predominantly white or wealthy neighborhood. So, this is an example of how race and social terms of health intersect, and they create poor outcomes, particularly for these residents. We can talk a little bit about this in the Q&A. So for the second example, I'm going to talk to you about is Black maternal mortality. So in the US, Black women are 3 to 4 times more likely to die during or soon after childbirth, right? In the United States, our maternal mortality rates for Black women are more similar to developing countries than they are to wealthier developed countries like New Zealand or the UK. And so some of the reasons that we can look at why this is happening, and some of the reasons that we kind of fall back on for that are supposed to give us proper health, but don't really work in this case. So if you remember the list of social determinants of health, I said that education is a social determinant of health. Usually, the more education you have, the more likely you have to better health. But for Black women, it's sort of the opposite. So in this New York City study found that college-educated Black women were 3 times more likely to experience severe maternal complications, including death, than a white woman without a high school education. And so here, this is sort of the thing, like education won't save Black women. Black women are some of the most educated group population in America, only rival to that of white men. And yet, despite having one of the groups with the highest rates of professional education, like JDs, MDs, and PhDs, it's still not stopping them from dying during or soon after childbirth, right? Particularly black middle and upper class women are still more likely to die of childbirth than white women with very low income. So even income is not saving Black women. So some contributing factors, lesser access to healthcare. Even Black wealthy women had issues assessing healthcare. One, it's because of location. Black women, even though they're wealthy, Black families, middle to upper class, still tend to live in poor neighborhoods. They also have higher student loan debt than Black women have the highest rates of student loans. There's also income inequality. Black women make less than white women, and white men, excuse me. And then also more likely to work low wage jobs if they are lower socioeconomic status. The jobs that we deemed essential yet paid low during the pandemic, like grocery store workers, gas station clerks, those kinds of things, are predominantly worked by Black women as well as brown women. And yet, these are just some of the stressors that we have to think about when we're talking about Black maternal mortality. Another big thing that we have to talk about is weathering. Weathering is something that all people experience who have social disadvantages in their life. Weathering, though, we have found that it particularly affects Black women, and it particularly affects their unborn child because it can be passed on, the effects. So weathering, I always like to think of something being left outside to the elements. Like, think of a t-shirt and you left it outside for a few years. It would be exposed to rain, the sun, maybe get run over by a car, right? And then if you went back a few years and you picked it up, it would not look like the original shirt that you left outside. Weathering is that kind of same effect on the body. Social disadvantages like racism and discrimination, they literally corrode our health. They weather us, right? And we usually see those effects in the form of stress. And then racism, of course, stresses the body. So we have things like the cortisol effect. Cortisol effect, sometimes called living while Black, is the physical and physiological response that your body has to racism. So when if you're a Black person and you're being pulled over by a police officer, especially now that we're having lots of news coverage about Black people being pulled over where they did not end up with their lives, right? So cortisol effect is when your body has this stress response to situations where you're anticipating racism. Sometimes it's also called hypervigilance, right? You're on alert for racism, and that has a physiological response in your body that is not great. Weathering or the stress of racism also ages us, right? There's been studies that show that the stress of racism, it shortens your telomeres, which are the ends of your cells, and that control aging, right? So racism literally ages people quickly by shortening and aging their cells. And of course, this leads to premature death. This is one of the connections that people make between Black people's higher mortality rates compared to other races, is the idea of weathering, this experiences of the stress of racism, the stress of hypervigilance. And we're seeing this in women and how the stress of racism is passed on to their fetus. Women who have higher rates of discrimination typically have babies that have very low birth weights. But then also we're seeing it in their responses to giving birth. So for example, there's a study that talks about white women, how in their 20s, they're more likely to give birth to a healthy baby than those in their teens. But for Black women, the older you are, especially when you hit that sweet spot where women are supposed to be a prime birthing age, it's actually more dangerous for them to birth than if they were younger because they've experienced more weathering. So when a Black woman reaches that sweet spot of where they're supposed to be able to birth successfully and safely, it's actually worse for them than if they were white because now they've had more years to experience weathering than if they were younger and they hadn't been weathered as much, right? They hadn't gone through as many racial experiences in their life. So this is just another example of how social determinants of health, the ways that we socially live in the world, can cause poor health outcomes for Black people. There's also provider racial and gender biases. So we have research that talks about it separately, but for Black maternal mortality, because you have Black women who have to deal with their womanness and their Blackness and how they intersect, we have to think about how providers like physicians and nurses, how their documented biases against women and their documented biases against Black people sort of intersect. So we have studies that tell us that providers themselves have certain biases against Black people and have certain biases against Black women. They have been shown to equate Blackness with being poor, being uneducated, not following care recommendations, and being just unworthy of healthcare. They are seen as exaggerating their pain, as being drug-seeking individuals. And then also there's some historical biases that are at the very foundation of medicine. The very foundation of medicine has these biases against Black women and these thoughts that they are promiscuous or over-sexualized, or that they birth lots of children with no regard to how to care for them, or this idea of welfare mothers. So if you think about, if you're a physician or a nurse and you have these ideas, whether they are explicit or implicit, whether they are subconscious or conscious, and you have these ideals about a Black woman, think about how that may then translate into treatment. If you think that Black women are poor and uneducated or exaggerating their pain, that might lead you to do things like not care for them as well, to not give them the pain management that they need, to not care for them as much as you would, say, someone that you did not have these biases about. And then quickly, I'll go over some stereotypes we have documented as well from providers. Providers have said that they think Black girls are less nurturing, need less nurturing, that they need less protection and less support and less comfort because they are strong and sturdy. That Black girls are more dependent, Black girls know more about adult topics like sex. That Black women tend to be stronger, more mentally and physically, and so that then leads them to believe that they need less attention, less care. There's also an issue listening to Black women. When you look at some of the testimonies and the stories from Black women who had complications with their birth, or you listen to the families of the Black women who have died during or soon after childbirth, you see this trend of feeling not listened to. When they say, hey, I think something's wrong, maybe we should call the doctor, the nurse says, you're fine, don't worry about it. Or they'll say, like, I think maybe I'm not feeling right. Again, fine. And we have many ways that Black women have found to combat this, or many steps that they take to combat racism in medicine. So they'll do things like they will, if their husband or their spouse is white, they will bring in their spouse to make sure that they get some recognition, that they're seen or heard. They'll bring in white family members. They'll dress very professionally. They will wear their badge to their job, so that way the provider knows that they have a job. They'll casually mention in conversation like, oh yeah, I have to get to the law firm after this, so that way the doctor knows that they're educated and that they have a job, and maybe they'll be seen and heard and be treated with respect. So thinking about these extra steps that Black women take just to make sure that they get just decent care that a white woman would get. And I always try to give stories. I'm writing a book on Black health that is about what I've told you, but mostly about people's stories. And these are two Black women who have been in the news in the past few years. They both died soon after childbirth. The first one, Shalon Irving, she was an epidemiologist at the CDC. She had lots of complications after giving birth to her daughter. Many doctors ignored her. They ignored her swelling. They ignored her rapid weight gain. They ignored her hypertension. And she soon died, maybe within a year after giving birth to her daughter. Shanice Wallace was a resident herself. She was a doctor in Indianapolis. She died soon after giving birth, after making complaints about not feeling well, some bleeding that she was having. She was ignored, and she died just days after giving birth to her family as well. So I think it's really important to remember that these statistics, these things that we talk about, have real life implications for people. These are now children without mothers. These are now partners who have lost their partners now. These are parents who now have lost their daughters, right? These are communities who have lost people. These are now two very educated women who we don't have. And this is another example of how their education did not stop them. They had MAs, PhDs, MDs, and yet they were still ignored. So think about if a poor woman comes in, how will she be treated? These two very wealthy, I mean, not very wealthy, but upper middle class, very educated women could not even get their doctors to listen. Think about what chance a lower socioeconomic class person might have as far as getting listened to by their providers. And then there are also structural barriers that we have to think about. I'm in medical education, so I frequently think about how we teach medical students about race and racism, how we teach them about risk factors, even the kinds of books that we look at, right? Obstetrics books sometimes don't talk about the history of obstetrics and how Black women who were enslaved were the foundation of how we know a lot about gynecology and obstetrics. Dermatology textbooks sometimes, not sometimes, most of the time, do not have pictures of how to recognize skin disorders on Black skin, right? So our dermatologists are graduating school and not knowing how to care for Black patients. We have to think about clinical care, right? How some of our algorithms, some of our diagnostic tools, some of the ways that we treat people have racism built into them, right? Thinking about pulse oximeters, the machine, right? The pulse ox that you put on your finger, right? We found that they are very popular now during COVID because they can tell you about your lung function, but they don't pick up darker skin. But yeah, this is a tool that medicine relies on. If you ever go to the doctor, one of the first things they do is they weigh you, take your blood pressure, and then they put a pulse ox on you. But if you have darker skin, it's not as accurate, but yet we're using this as a part of medicine. So just thinking about racism in medical education and then racism in clinical care. And also in the way that we think about medicine. So if you all know, may be aware of the recent controversy about JAMA, Journal of American Medical Association, in their podcast, and how they asked, how can doctors be racist, right? They don't believe doctors can be racist, or they don't believe racism exists because it's illegal, right? This is a very well-known journal, well-known podcast that many physicians come to rely on. And if this is a representation of medicine, then there's a real problem if medicine itself doesn't think that doctors can be racist or that structural racism doesn't exist. When for so long we had white physicians using false race-based science to justify things like slavery, to justify eugenics, that Black people were biologically and inherently different and therefore deserving of less things. That white and Black hospitals and medical schools were legally segregated. Up until the 1960s, the AMA would not call Black doctors anything other than colored doctors. This is up until I think maybe 1968. We have documented research that tells us provider bias is something very real in medicine. The AMA was very slow to take a stance on racism as a public health issue. They finally did it in 2020. And then yet again, medicine has yet to take widespread responsibility for the mistakes and its role in medical racism. So what can be done? I don't want to end without telling you, what can we do? What should we be thinking about? How can we act? What kind of behaviors we can make? What kind of change can we demand from our healthcare systems? So one thing that has been a positive step for Black maternal health is in California, the governor signed a bill saying that anyone working with pregnant women, anyone working with newborns, that they have to take provider bias training. And provider bias training has really shown to do some good, but it has to be done often. You can't take one-time implicit bias class and then think you're no longer biased and that's the end, right? It has to be something that we constantly work on, but this is one step. North Carolina is also another example of a state that did something about the Black-white maternal mortality gap. They have almost entirely closed their gap. And what they did was they used sort of a form of social work. First, they incentivized doctors to identify women who were at risk, and a lot of these women were Black women. They paid them for their time for identifying women who are at risk for death or for complications. And they used sort of social workers to help patients minimize those risks. So let's say a doctor said this woman is at risk for diabetes. Social worker then makes sure she knows what diabetes is, make sure she knows about behavioral and life changes, make sure she knows where and how to pick up her medication, make sure she knows about healthy eating and exercise. And so it's really an intervention that the state of North Carolina really threw money at. What they did was they expanded Medicaid, and they really threw money at a problem and said, how do we help these women? And let's have more intervention. They made sure they had housing, they made sure they had food, right? These are all ways that they sort of closed this gap. If you've seen on the news lately, just maybe 2 days ago, President Biden issued the first statement that the White House has ever issued, any president ever issued on Black maternal mortality, and sort of some federal goals and some suggestions for states on how to end maternal mortality. And this is really, really huge. No president has ever acknowledged that this problem is happening. And this is one of those large scale, big picture actions is policy. Right, that's one of the things that I advocate for in this big picture action, is that there has to be institutional policies, sorry for the typo, institutional policies in healthcare and in public health that address social determinants of health and the inequities that exist in them. We have to have better data on disparities so that way we know how to target public health campaigns. And one of the biggest big picture actions that's probably the hardest and most complicated is this collaboration with all of these different systems that affect our health, like education, housing, labor, justice, transportation, agricultural, and environment. All of these institutions affect our health, and yet they have to work together because they are so interdependent. It also requires us to look at policies, practices, norms that create inequities and social determinants of health. And also the systems of power, right? The fact that President Biden is starting this off, I think, is a very big step. Now, if you're like me, most people, you're looking at these and saying, okay, what am I supposed to do? I'm not going to be the person that brings together education and labor and justice to make sure that we have things like better health outcomes for people of color. But there are individual things I think that physicians and researchers can do. So I'll give just through a couple of these. So one, include patients of color in our research. You will be surprised how very few people of color there are in research. It'll say things like, you know, we interview 2,000 white people, 500 Asian people, and 2 Black people, right? And then say that this research represents the general public, and that's just not true, right? Recommend patients of color for clinical trials. Interrogate your own biases, whether that's taking the IAT test from Harvard online, your implicit bias test, whether it's looking at implicit bias books and training, if your institution offers it. I know my medical school, we started doing it for our second year medical students, and they found it very helpful to have these classes and this training about what does it mean to have a bias, because we all have them, and how can we confront those biases. And if you are aware that you have a bias against fat people, against transgender people, against Black people, against poor people, whatever, call out your biases, interrogate them, but stay on alert. Maybe that means asking a colleague for help to make sure that you're not using your biased attitudes to treat a patient. Maybe that means asking for a consultation. Maybe that means learning about your own biases. And then, especially if you are in charge of your offices or your labs, you set the tone. You set the tone for what will be tolerated and what won't. So set the example that racist behavior will not be accepted. Ask patients if they face any barriers, sort of address the elephant in the room and say, have you been experiencing any sort of effects of racism? And if they don't want to talk about it, drop it. But I bet a lot of people will be refreshed by it. And then also advocate. Ask your institutions, what are they doing to make sure that we don't have racial disparities in health at your institution? What are they doing to combat inequities in social determinants of health? And then there are a lot of advocacy groups who are already doing this work. Support them, whether that's with time, whether that's with making their work known, whether that's with money. But we have groups that are really, really working on this. Black Mamas Matter Alliance is one that works on Black maternal mortality. Get behind these groups and support them. So in conclusion, race and social determinants of health intersect, and that's how we have to think about poor health outcomes for Black people, is looking at the intersection of race, racism, and social determinants of health. Think about how race worsens health outcomes and how social determinants of health worsen health outcomes when you don't have access to them. There are individual macro level solutions, and if there are more you can think of, we can talk about them in discussion. But there are measures that clinicians can take. There are measures that researchers can take. Even in the ways that we do our work, we can be anti-racist in them. And then overall, I just want to leave you with the idea of what does racial justice in medicine look like? What does racial justice for Black people look like? So that's it. I really appreciate you. There's my email, Twitter, if you want to follow me. I will stop sharing and turn it over.
Okay,
Okay,
thank you so much, Dr. Ray. Lovely. Yes, applause.
thank you.
We have plenty of time for questions. If you'd like to ask your question verbally, you can hover over your name in the participants list on the side, and the little hand icon will appear. You click on that, and it'll raise your virtual hand. Then I'll click it for you to unmute. You have to unmute yourself, but I have to click first. Otherwise, if you want to type your question, you can type it into the chat. And I see someone has typed a question that asks, what are some of the ways Dr. Ray has experienced racism in her life? I think medical racism maybe is what the question is asking
Sure.
about. Yeah.
Yeah, I've written about this. I am an editor for bioethics.net. It's the blog for American Journal of Bioethics, and I've chronicled some of my experience with racism there. There have been a few, some related to today. There have been one seeing a doctor, and he just couldn't believe that a Black woman of my age has never had a baby or never been pregnant. He kept pushing and pushing. He said, "Are you sure you've never been pregnant? Are you sure you've never had a baby? A woman of your age, right?" And he says, and then he said something, "I know your people tend to have a lot of children." And I said, and I'm one of those people who say, "Well, please explain. What do you mean, your people?" Right? Then he gets flustered and like, "Well, I didn't mean it like that." Something, something along those lines. So that's definitely happened. I've had doctors assume that I couldn't afford my medication. That wasn't very expensive at all, but they would just say things like, "Well, I know this might be hard for you," without any sort of question about my financial status. And I know that I mentioned how sometimes Black women, when they are seeking maternal care, that they will do things to combat racism. I definitely do that. I make sure I dress well when I'm going to the doctor. If I'm leaving the gym, I hurry up and change out of my yoga pants, put on decent clothes. I wear my badge that says PhD, working at the medical school that's across the street from the doctor's office that I'm seeing. I've noticed that I get a better response when I do those things. They talk to me better. They talk to me as if I can understand what they're saying and be a participant in my care. I have a few chronic issues, so I have a lot of interaction with doctors, and I found that, doing these little things gets me better care because I have had, and I remember, like I said, things biases sort of intersect, right? So I've had my Blackness, my womanness, and my fatness all sort of intersect in doctors, right? Of racism, fat phobia, and sexism sort of interact all together. So that's really important to think about that when you have a bias, usually they work together. You're never just one thing when people look at you. It's a biases of all sorts that sort of intersect. So yeah, I've had my fair share. I have a couple stories out there floating around the internet.
Okay, thank you. Julian Gonzalez asks in the chat, do you see your project as being an epistemology of inclusion and diversity related to Longino's feminist epistemology?
Yeah, I can see that. I think overall, I try to just make sure that I don't use epistemological violence or epistemological injustice, those terms, but that's essentially what I'm talking about in my work. Um, one of the things that's really important for me, given the topic, is that my work is accessible to people who are not just academics. So, like the book that I'm working on is written very accessible, layman's term. This is meant for if you're a freshman, 18-year-old coming out of high school, that you can be able to read it. And I think even my presentations, what I try to do is make sure that they are accessible, because this is the kind of topic where I don't want to use philosophical words or jargon to make sure that it's accessible. But ultimately, yeah, it is. I can see where you would make that connection. Um, it's definitely a project on epistemological violence, especially the section on not being believed, right? One of the issues with Black health is that Black people are not seen as reliable narrators of their story, right? They're not seen as trustworthy to tell a doctor or nurse practitioner what is wrong with you, right? It has to be that we're lying, you're not telling me the truth. So yeah, I can see, and there's definitely some feminist bioethics in my work, so I can see why you would make that connection. Yeah.
Okay, we have a hand raised by Galen. Uh, Go ahead and unmute, Galen.
Hello. Yeah, thank you for your talk. One thing that was really interesting to me is this whole idea of weathering. I think one of the kind of like prevailing ideas of African American in the health community is like you always hear about it, that they have more of a risk of hypertension, and African Americans have like a genetic predisposition to heart disease and stuff like that. I wanted to hear your take or your opinion. Is that also a product of weathering? This idea that African Americans have a predisposition to hypertension, and if it is a product of weathering, how far back did that kind of become a trope in the medical community? Like how does that become incorporated into like the national kind of sentiment?
Sure. Yeah, that's a really good question, because it's the idea that Black people have a predisposition for heart disease has been so ingrained in medicine. I can see research as early as the 1900s, like 1902. There's an article. I'd say around the 60s and 70s, it really became this idea that Black people were predisposition for hypertension because of the Atlantic slave trade. If any of you may have heard this story, right? Where because of the poor conditions in the slave trade when being transported from all parts of the country, Africa, Caribbean, over to different Western countries, that the poor conditions, the Black people who survived were the ones who were able to retain water better, right? They didn't die of dehydration and thirst and those kinds of things. And so if you know anything about hypertension, there's some issues with retaining water, right? So it was seen as sort of this evolutionary response of why we have hypertension, is this evolutionary response to these social conditions of the Atlantic slave trade. Um, and that honestly, there's still people around who still believe that, but it has been debunked so many times. There's so many articles and so much research from scientists showing us that that is actually not the case, right? And that the cause for it are social causes, right? Black people are not predispositioned for cardiovascular disease. It's social causes. So I'm glad that you brought up weathering, because weathering, we know the stress, the cortisol effect, all can raise blood pressure. There's also some beginnings of research to show that it can also be intergenerational, which is why hypertension can be hereditary, because we pass on trauma, right? If anyone has had trauma, parents experience trauma, and then it gets passed on to you, whatever kind of trauma may happen, racial trauma gets passed on through the generations. So that is one explanation for why heart disease may be hereditary. You're right, and I say it with quotes, hereditary, because it doesn't have to be, right? But that it gets passed on. And it's not just, racial trauma in the family, it's turning on the TV and watching a police killing, right? It's going to being the only Black person in a room in your high school or your grad class, right? It's all of these sort of racism and racial experiences that are thrown at us from the moment you wake up till you go to sleep, right? And so that is really how we tend, or how I at least, I wouldn't just say me, lots of people tend to explain heart disease in the Black population, right? Is a more of a social connection. Because if you just do a Google search for Black and hypertension, there's so much research that's saying not biological. We can't find a biological thread between this. It's social. And one of those, like you said, weathering. Yeah.
Okay, Kate Davies. Oh, I gotta hit the button.
Okay, can you hear me now? Great. Thank you so much, Dr. Ray, for this presentation. I'm so compelled by your argument here. I have a question, and this is coming from my own research a little bit, so it's a little selfish. I'm researching foster care and social work and the foster care system. And it really struck me when you presented these findings about the North Carolina sort of closing the gap on maternal mortality. And I was curious because social work seemed to have intervened there in a way that was very productive, right? And successful. But there are so many cases where, especially Black and Brown communities, find their children taken into care in sort of intersections with medical contexts, right? So especially even right at birth, a lot of children are removed, right? Because there's duties to report certain kinds of risk factors that I think you've very compellingly shown have to do with more social determinants of health, but that are sort of attached to subjects as let's moralize and shame them and punish them. And so I'm wondering about the intersections of these different structures with medicine, right? So like social work.
Yeah, I think social work is one of the least talked about, but one of the most invaluable parts of racial disparities in health. Because I think North Carolina, I always talk about North Carolina because it really showed that the ways we think we should end racial disparities haven't been working. And then this state, sort of this case study, showed us this is really how you do it. You back it up with policy, you back it up with money, you back it up with personnel, you back it up with resources, right? And I think social work in this case was really that it's the resources, right? And then also, social work can be overworked, underpaid, right? So there has to also be some reformation there to make sure that they are properly staffed and properly functioning so that they can then go in and do the work and help these families too. So there's definitely some overlap. I think social work might be an answer to a lot of other problems as well. But I do think, like you said, there are still racism is everywhere, right? Social workers are not immune to racism as well, right? Who gets reported, who gets children taken away, who gets seen as an improper home, improper malfunctioning parenting, right? Those kinds of things. And so I think even social work itself can benefit from some, and it has to be more than implicit bias training, right? It has to be more than throw a class at it and then move on. It has to be this continuous practice. So yeah, so as far as the intersection, there's definitely intersection there, and I wish there were more, right? Because I can even see it. I think some of the environmental racism stuff could have benefited from some social work, as far as this problem was just hidden for so long, and I think the people themselves had to sort of navigate this issue themselves, and especially the children in their neighborhood. And there's also this story of this child who kept having these mysterious illnesses, and social work did intervene because they thought that it was something like the parents were making this kid sick, because he kept going to the doctors, he kept having these exploratory surgeries. The doctors were not finding anything, right? So they just immediately went, maybe the parents are doing something to him, maybe there's something that we don't know, maybe he was losing weight, they thought maybe he wasn't being fed, right? So it was this sort of, if there was this bigger, if the issue of environmental racism was more widely known, maybe this family wouldn't have had to go through all of these problems of thinking that they're unfit parents and the scrutiny that goes with that, right? And everyone knows that there's child protective services and social workers, at that home. And really it was his home was making him sick. The vegetables that his grandparents were growing in their backyard that he was eating was making him sick, right? He was having all these gastrointestinal issues. And that's where I think, like you said, sometimes social work can be racist in that way, where we sort of start attacking Black families for doing certain things. But yet, I still think there can be some intervention there that's valuable for social work, and some intervention in racial determinants of health that social workers can really be invaluable for. Yeah, so I know it's a roundabout way of answering your question, but yeah, I think there has to be more of a connection between social work and racial determinants of health, social determinants of health, and racial disparities in health. And I think that that could really be valuable to ending them. Yeah.
So we have a question from Melissa Smith in the chat. She writes that she was really compelled by the relationship between environmental ethics and bioethics that you articulated, and wants to know if there are any activist organizations that the general public could engage with that focus on that intersection. And she's also in Houston, so local would be helpful for her.
Yeah, you know what? Email me and I'll have to think of some, because the ones that I know are local to my university, my at UT Health, in the medical center, we have a student group who actually goes out into the community, and they're doing some help with testing of soil, interviewing people in these neighborhoods. They're really doing advocacy and trying to get them attention, because one of the issues that people are experiencing environmental racism having is people listening, right? We already have a part of the population who doesn't believe in climate change and those kinds of issues, and then to say it's affecting Black and brown people, it's affecting poor people, here's how. They're having a lot of issues being heard. So there's a student group here I know on campus who is really helping with just trying to get it made popular, right? Like, hear their voices. So email me keisha.s.ray@uth.tnc.edu. I can put it in the chat, and I can connect you with some. I'm sure they'll have recommendations for some Houston ones, because they do work with local Houston groups. So I can get that to you.
Okay,
I'll put
great.
that in the chat.
We have another question in the chat from Samantha Milla, who asks, how do we advocate for ourselves when we are confronted with these stereotypes while we are receiving care?
One powerful piece of advice that I sort of had to do, it's really unfortunate that you have to advocate for yourself. I always feel very sad too for people who are introverts. I am not an introvert, so I have no problem with saying, you're doing me wrong. I need a new doctor. I want to talk to someone. This is not right, right? But it's a shame that you have to do that. You should not have to go into a clinician's office and have to already go in there combative and ready to fight for yourself, or already preparing for that. But one thing that you can do is, it's a class issue too, because some people have money to find a new doctor, some people don't, right? I have the finances where this doctor I feel like is not treating me properly, I can go pay my copay at another doctor. I can do some research, right? One thing I would say, do your research on your doctor. There are lots of forums that say, I had this experience with this doctor and I think it was racially motivated, here's how, right? First, do your research if it's a matter of money, where you can't just shop around to the doctor, which is an issue for a lot of people. I understand that. Second, there aren't a lot, but research has shown physicians of color are good for people of all colors, white, Black, brown, whatever. But again, Black people are like 3% of physicians. Latino, I think, are 4, right? So even that is not enough to go around. But one thing that I found really helps is ask your doctor to document everything. If your doctor says, I don't think that this test is good for you, ask them to put that in your chart, right? One, it helps you to have a paper trail, but then also it helps you if you do have to go to another doctor to kind of see what treatment you already got. But a lot of times it forces that doctor to think about why they won't give you that test, right? I've done it myself, and actually I've done it twice, and it always turned out, okay, fine, we'll give it to you, right? They weren't kind about it, but I got the test that I needed, right? They weren't happy that I pressed them on it. It didn't create the best relationship, but I got the care that I needed, right? Again, because I have this sort of personality where I don't feel bad or I don't feel embarrassed to do that, it sort of helps me. But if you are an introvert or you're a person who is afraid of that confrontation, I can understand. I would say bring someone with you if you can. I know right now in the pandemic, having people in the office is not easy, but I say some offices are getting back to that. But if you think that you might experience poor care, unfortunately, do these different things Bring someone with you. If you can, again, I hate saying these things because you should not have to do any of this. You should be able to go to the doctor in your gym clothes, in your sweats, and get good care, right? Unfortunately, that's not the case, right? But yeah, these are some of the things that can help. Again, I know they don't sound great. I hear myself as I'm saying them, but these have been tactics, even that patients who have chronic illnesses, when I go to my talks, they'll talk to me in the audience and they'll say, this worked for me. I told my doctor, documented, and all of a sudden I got an email saying I've been scheduled for a test, right? These are some of the things that have helped them. Unfortunately, some people, people of color, people who are transgender, fat people, people with disabilities, these are just some of the measures that people have to take to get the care that they need.
Okay. Aisha asks whether you have any advice on respectfully addressing healthcare professional coworkers or bosses when they express casual racism in the workplace. She says, as someone pretty low in the hierarchy and as a woman of color, I always feel repercussions in these situations.
Yeah, this is a tough one. This is something that I talk to my medical students about because they will definitely say things like, my attending said this racist joke. What can I do, right? I'm worried about my evaluations that they write for me. I'm worried about the letters of recommendation. I'm worried about getting into fellowships and that kind of thing. One thing that I can say, there is a lot of power in not laughing and not responding. It's one of those kind of passive ways that you can respond that tells people in the room, this is unacceptable, right? Even I know sometimes we can have like a nervous giggle or nervous laugh as if like, this is not funny, but I feel compelled. Not responding is super powerful. I've had a lot of students that tell me that's the one thing that they feel that they can control is the entire group or this attending and this person is laughing and you're not laughing, right? Asking questions. I often play dumb. I don't get the joke. Why is this racist? I don't get the joke. Why are Black people supposed to be good at basketball? I don't get it, right? When people have to explain the joke, it's not funny. It's just not funny anymore. That's one thing. But then also, find what how your institution does reporting, right? A lot of institutions have reporting that you can do it anonymously, and if you can do it anonymously in a way that it won't come back to you, I would say don't let it go, because if physicians, attendings, if they get a lot of reports, things happen. You don't want to be the person that just keeps letting it go and another person lets it go and another person keeps letting it go, and then nothing happens, right? No change happens. But if you can do it in a way that you feel comfortable, like there were 10 people in the room, if I report it, it's not coming back to me. It could be any 10 people in the room, report it. Find your anonymous reporting at your institution. And if they don't have anonymous reporting, that's when you go to student affairs and you say something has to change. My own school had a sort of reckoning with anonymous reporting, and so many attendings started getting in trouble, started being taken off of teaching duties. Teaching is a privilege. That is not something that we just should give to everyone. They should not be in charge of medical students, interns, residents, whatever, if they can't do it properly. So those privileges get taken away if you start reporting. So report.
Okay, we have a question from Peyton about the COVID-19 vaccination argument from earlier in your talk. How would you explain to the population why one race gets access to the COVID vaccine before others? So how would we publicly defend that kind of prioritization?
Sure. Numbers, right? Numbers don't lie. We have all of this research that shows us Black, Brown, Black, Latinx, and Indigenous people have higher hospitalization rates. They have higher infection rates. And they have higher death rates. They also have higher rates of dealing with the adverse social effects. Higher evictions. Right now, Black women have the highest evictions related to COVID. We have in the foster system, because of COVID, Black and Latinx children in this country, the numbers are growing because of COVID for those two groups. And hopefully that should be enough. I get it's not going to, some people are going to be unhappy. At this point, it's the United States. A lot of people are unhappy. You're always going to be unhappy when you do the right thing. It's just not a compelling argument that some people are going to be unhappy to me anymore. That doesn't mean it's not the right thing to do, right? If you have people who are dying from this disease, why wouldn't they be the first one for protection? They're the ones that are getting vaccinated and then going back out and bagging your groceries. They're the ones going back out and cleaning hotel rooms, cleaning homes, doing all these kinds of things. So why shouldn't they be protected? So that's how I would argue. Numbers.
Okay, great. We have another question from Tim Morris. After your discussion of hypertension, I'm curious about other medical conditions. Given that sickle cell disease is estimated to occur in higher rates among African Americans, do you believe this estimate is a myth? Or if not a myth, is the higher rate of the disease influenced by biological or social factors?
Sure. Oh, so what's important to remember about sickle cell anemia is that it's not higher in African Americans, it's higher in Americans that have West African ancestry, right? So sickle cell anemia is not a race thing, it's an ethnicity thing, right? We just sort of group it all and say African American. But if you look at the actual ethnicity of the groups, it's higher in. And so one of the bigger issues with that is that's another group of people um, whose voice is not heard, right? They have pain episodes, but because they are racialized as Black, they go in saying, hey, I'm having this extreme pain, this high dosage of opioids not helping, right? Then they get labeled drug seeking, they get labeled exaggerators, right? Then they are part of the Black population whose pain is not properly managed. So that's really what I'm more concerned about with sickle cell anemia is how do we make sure that provider bias doesn't interfere with their pain management, but remembering that it's an ethnicity issue, not a race issue. And sometimes they're the same thing, but sometimes they're not. Sometimes we use them interchangeably when we shouldn't, but always keep in mind it's with people with West African ancestry.
Melissa Smith wants to know if the phenomenon you described as weathering has something to do with epigenetics, and if there's literature on that.
Yeah, there's a little bit of epigenetics, I'd say. Most of the literature that's coming out, mostly out of Harvard, a little bit out of Oxford, but most of it is a social phenomenon that then has physiological effects, right? So yes and no. I would say I would primarily look at weathering as this sort of yeah, like I said, this social factor in our lives that doesn't have to exist, right? We can get rid of weathering. This is not something that has to be a part of anyone's life, right? And also to keep in mind, weathering goes beyond race. This is just how I showed how it affects Black women. But you can have poor childhood experiences with emotional abuse, physical abuse, whatever, and be experiencing weathering, right? Because of the cause of your trauma. You can have PTSD from event and it caused weathering, right? So weathering is sort of widespread and has widespread effects. Essentially, the stress of disadvantages can hurt your health.
So I have a question about we, a lot of people who have emphasized the social determinants of health have also, I don't know about a lot, but some of them have also really tried to de-emphasize the importance of medical interventions in healthcare in favor of population health and public health sort of issues. And definitely in your talk, you had both kinds of recommendations, both at the medical and the kind of non-medical level. I wonder what you think the relative weight or importance is of medical versus non-medical interventions in addressing both improvement of health generally and improvement of health inequalities and injustices.
Sure. So I have some other work on children's education and using medical resources to end their inequalities there. And because I believe that medicalization is not an inherently bad word. I do think though that it can be temporary. Using medical resources to fix a social problem can help, but it's never going to be the long-term solution. It can be short term, it can help the individual people who are experiencing the issues at the moment, but if we want long-term successes, then that's where I think the social changes have to happen. But I don't think medicalization has to be this horrible word. We can use medicine to fix these issues, especially since medicine is a part of the problem, right? Provider biases, structural racism in medicine, the algorithms, the tools that we use to treat people of color, and how they can be racist. Those have to change, and that is a medical problem that needs a medical solution. So I believe in it, it has to be a two-part response to how we talk about social inequities and social determinants of health and poor outcomes for Black people. Yeah, I think it's both.
Okay, thank you so much. Well, please join me, everyone, in thanking our speaker today. That's all of our time. Thank you so much, Dr. Ray.
Thank you. I appreciate everyone coming. I know we all can be zoomed out, so I appreciate you all coming.
And I also appreciate everyone for attending today and enjoying our lecture. And I hope you'll join us next week when Anthony Ryan Hatch is speaking. And you should be able to find that at the Center for Values website. The link for that is values.utdallas.edu. All right. Have a great weekend.
Thank you. Thanks, Matt.
Okay, that's it. I didn't start the recording. I don't think I can stop it.